Hello my dear friends. So as a part of the continuation of the ECG series, in this session, let me discuss about the miscellaneous waves in the ECG. That is, the Osborne wave and as well as the Epsilon wave. So if you take the Osborne wave, the another name of this particular Osborne wave, this is also called as the J wave. Now first of all, you need to know what exactly is the J point. Then you can understand what is your J wave. So if you take this J point is present at the end of the S wave and the starting of the ST segment. That is what is your J point. So this is the J point. So this is the point which is present at the end of S wave and the start of the ST segment. So that is what is your J point. Now any particular positive deflection or any wave which appears at the J point, this is what is called as the J wave. So you can see that here, right? You can see that here. So this is the J wave. So it is a positive deflection which is present at the J point. And this particular J wave is nothing but your Osborne wave. Now let me just show you another ECG strip with the J wave. So if you take this particular ECG strip, you can see that there is a small positive deflection which is present at the J point, and this is what is called as the J wave. Okay. Now what are the conditions where you have the presence of the J wave? You have the presence of the J wave in case of the hypothermia. Now what is the normal body temperature? The normal body temperature, if you take, it is around 37.2 degrees centigrade. Now when the body temperature reduces to 32.5 degrees centigrade, that is the point when you have the presence of the J wave. And always remember, the amplitude of the J wave is roughly proportional to the degree of hypothermia. Right? The amplitude of the J wave, it is roughly proportional to the degree of the hypothermia. So that is what is nothing but your J wave. Where is that seen? It is seen in patients with the hypothermia. Now, if you see this J wave or Osborne wave, it is not just seen only in patients with the hypothermia. Apart from hypothermia, you have many other conditions where you have the presence of this particular Osborne wave or the J wave. Okay, but before that, let me tell you, the Osborne wave or the J wave, it is a positive wave in the sense you will have a positive deflection above the isoelectric baseline. But only exception is that this particular J wave or Osborne wave, it is a negative wave in AVR and as well as V1. Right? It is a negative wave in AVR and as well as V1. And always remember, this particular J wave, it is most prominent in the precordial leads. Right? It is most prominent in the precordial leads. Okay. Next. Now let me tell you what are all the conditions, what are all the other conditions where you have the presence of this particular J wave or the Osborne wave. Yes, you see this question. Causes of non-hypothermic Osborne waves include all except, the options are normal variant and early repolarization, acute myocardial ischemia, hypocalcemia, Takotsubo cardiomyopathy. Remember, the Osborne wave is not seen in patients with the hypocalcemia. Right? So if you take this particular hypocalcemia, right, that is your third option. In remaining all conditions, you have this particular Osborne wave or the J wave. Now let me discuss about the individual options and the other respective ECG waves. Now you take early repolarization. We also call this as benign early repolarization. In benign early repolarization, apart from the presence of the J wave, there will be also ST segment elevation. And this ST segment elevation, it is concave upwards. Right, it is concave upwards. And this ST segment elevation, which is concave upwards, it is present in the precordial leads. Right, it is present in the precordial leads. Okay, so that is about your benign early repolarization. Then coming to your acute myocardial ischemia. Acute myocardial ischemia, the ECG changes that are being present is there can be non-specific STT changes, that is ST segment depression can be there or cannot be there, and there can be also T wave inversions. So this will be the ECG changes in acute myocardial ischemia, and along with that there can be presence of this Osborne wave, or which is also called the J wave. Now coming to your Takotsubo cardiomyopathy. Takotsubo cardiomyopathy, please remember, this is also called as stress cardiomyopathy. Right, this is also called as the stress cardiomyopathy, or the another name of it is nothing but apical ballooning syndrome. Right, it is also called apical ballooning syndrome. So that is what is your Takotsubo cardiomyopathy or the stress cardiomyopathy. Now, in case of the apical ballooning syndrome, what is the criteria? There are four important features that have to be taken into the criteria of the Takotsubo cardiomyopathy. Now, what are those four important features? Number one, there should be ST segment elevation in the ECG. That is very important point. Number two, the two-dimensional echocardiography should show the presence of ballooning of the apex of the left ventricle. That is your 2D echo, right? What is the 2D echo shows? Ballooning of the apex of the heart. Number three, the coronary angiogram should be absolutely normal. That is the third important point. And there should be absence of pheochromocytoma, because in stress cardiomyopathy, that is Takotsubo cardiomyopathy, they're mainly because of that particular condition is mainly because of excessive release of catecholamines into the circulation. And what is the other clinical disease where there is excessive release of catecholamines into the circulation? That is pheochromocytoma. In pheochromocytoma, there will be excessive release of catecholamines into the circulation. So, you should rule out pheochromocytoma if you want to diagnose the stress cardiomyopathy. And how will you rule out the pheochromocytoma? You have to check for the 24-hour urinary vanillin mannalic acid levels. Normal 24-hour urinary vanillin mannalic acid levels are less than 6 milligrams per 24 hours. But in patients with pheochromocytoma, the vanillin mannalic acid levels will be more than 6 milligrams per 24 hours. So, these are the points in your Takotsubo cardiomyopathy. That is a criteria. Number one, ST segment elevation in the ECG. Two-dimensional echocardiography should be showing the ballooning of the apex of the heart, and troponin should be positive. Coronary angiogram should be absolutely normal, right? There should not be any plaque or thrombus, and absence of the pheochromocytoma. If these four features are there, then we call it as Takotsubo cardiomyopathy. And remember, in Takotsubo cardiomyopathy, you can also have the presence of the J wave or Osborne wave along with the ST segment elevation in the ECG. Next, coming to your hypocalcemia. In hypocalcemia, you will not have the J wave or the Osborne wave. In hypocalcemia, what is that you will have? In hypocalcemia, you will have the QT prolongation. That will be the ECG change in hypocalcemia. What is a normal QT interval? The normal QT interval, it is around 360 to 440 milliseconds. That is the normal QT interval. But in patients with a hypocalcemia, the QT prolongation will be there. It will be more than 440 milliseconds. Right, it will be more than 440 milliseconds. That is what you will have in patients with the hypocalcemia. Whereas you take in patients with hypercalcemia, in hypercalcemia, you will have the presence of the Osborne wave. Right, you will have the presence of the Osborne wave or the J wave. Alright, now the next important point is in hypercalcemia, what will be the other ECG changes apart from the Osborne wave? Right, apart from the Osborne wave or the J wave, what are the other ECG changes in hypercalcemia? The other ECG changes in hypercalcemia will be short QT interval. Right, the other ECG changes will be short QT interval. Now, what do you understand by the word short QT interval? Where the QT interval will be less than 360 milliseconds. Right, so that is what is your short QT interval. Okay, right. So these are some of the conditions where you have the presence of the J wave or Osborne wave apart from the hypothermia. Now, apart from these conditions, we have many other conditions where you have the presence of the Osborne wave. That is left ventricular hypertrophy due to hypertension. In this clinical condition also, you can have the presence of the Osborne wave or the J wave. Now, if you take left ventricular hypertrophy, what actually is the criteria? The name of the criteria for left ventricular hypertrophy is Sokolow-Lyon criteria. Right, the name of the criteria is the Sokolow-Lyon criteria. Now, what is this particular Sokolow-Lyon criteria? This particular Sokolow-Lyon criteria is the one which is suggestive of left ventricular hypertrophy in the ECG. What is that? That is SV1 plus RV6. If it is more than 35 mm, then that is what is suggestive of left ventricular hypertrophy according to your Sokolow-Lyon criteria. Right, and in left ventricular hypertrophy, you can also have the presence of the Osborne wave or the J wave. Now, the other condition where you can have the presence of the Osborne wave or the J wave is in case of subarachnoid hemorrhage. Now, in subarachnoid hemorrhage, there will be raised intracranial pressure, right? There will be raised intracranial hypertension. Now, what will be the ECG changes in case of subarachnoid hemorrhage? The ECG changes in case of the subarachnoid hemorrhage will be the presence of the T wave inversion. Right, the presence of T wave inversion. And this particular T wave inversion is seen in almost all the leads. Right, this particular T wave inversion is seen in almost all the leads. Alright. Now, this we call it as cerebral T waves. Right, this we call it as the cerebral T waves. Okay. Now, cerebral T waves, they are your giant T wave inversions. Right, they are your giant T wave inversions. That is what you will see in patients with the subarachnoid hemorrhage. And in subarachnoid hemorrhage, apart from the giant T wave inversions, you can also have the presence of the Osborne wave. Right, you will also have the presence of the Osborne wave. Okay, right. Next, in case of myocarditis, these patients with severe myocarditis, they can present with left ventricular failure, and even in patients with severe myocarditis, they can have the presence of this Osborne wave. Now, coming to your Brugada syndrome. Now, what is this particular Brugada syndrome? Brugada syndrome, it is a sodium channelopathy. Right, Brugada syndrome, it is a sodium channelopathy. Now, it is the mutation of the channel, that is SCN5A. Now, what will be the ECG changes in patients with the Brugada syndrome? ECG changes will be ST segment elevation in V1 to V3, right? And that too, there will be coved ST segment elevation, right? That too, there will be coved ST segment elevation. Okay, so that is what you will see in the Brugada syndrome. Now, the another important point is, in case of the Brugada syndrome, there will be or there can be sudden cardiac death. Right, there can be sudden cardiac death. That is what you will see in Brugada syndrome. And what is the treatment of choice in Brugada syndrome? The treatment of choice in Brugada syndrome is implantable cardioverter defibrillator. Right, the treatment of choice in Brugada syndrome is implantable cardioverter defibrillator. That is what you will see in case of the Brugada syndrome. Right, so these are all the conditions now: left ventricular hypertrophy, subarachnoid hemorrhage, severe myocarditis, Brugada syndrome, and then benign early repolarization, acute myocardial ischemia, hypercalcemia, and tachycardiomyopathy. These are all the conditions where you can have the presence of the Osborne wave. Now, after having discussed about this particular Osborne wave, the next important wave that need to be discussed is the Epsilon wave. Now, this Epsilon wave, it is also a small positive deflection, that is a blip or wiggle buried in the end of the QRS complex, right? Buried at the end of the QRS complex. That is what is your Epsilon wave. I will just show you that. But what is the cardiac condition where you can have the presence of this particular Epsilon wave? So you will have the Epsilon wave in the disorders associated with the myocytes of the right ventricle. Right, it is seen in the disorder associated with myocytes of the right ventricle. See, this is the normal heart, right, where you can make out the normal right ventricle. And you take this ARVD, that is Arithmogenic right ventricular dysplasia or Arithmogenic right ventricular cardiomyopathy. In case of Arithmogenic right ventricular cardiomyopathy, what will happen is the myocardium it is replaced by the fat. Right, the myocardium is replaced by fat. So fatty replacement of the heart muscle. The muscle is replaced by your fat. That is what is your arrhythmogenic right ventricular dysplasia. Now, arrhythmogenic right ventricular dysplasia is also another condition where the individual can have the sudden cardiac death. And it is mainly because of the gene mutation. And it is an inherited disorder. And you should know what is the type of inheritance of the arrhythmogenic right ventricular dysplasia. Autosomal dominant type of inheritance, autosomal recessive, both, and X-linked recessive disorder. So please remember, the type of inheritance of the arrhythmogenic right ventricular dysplasia is both autosomal dominant and as well as the autosomal recessive type of inheritance, right? But typically it is inherited as autosomal dominant trait, okay, with variable penetrance and expression, but there is also an autosomal recessive form of inheritance of this arrhythmogenic right ventricular dysplasia. Now, what is that autosomal recessive form? This autosomal recessive form, this is called as Naxos disease. Right, this is called as Naxos disease. So, autosomal recessive form of inheritance is seen in the Naxos disease. And remember, ARVD, it can be both. It is inherited as autosomal dominant and as well as autosomal recessive. But the autosomal recessive form of the inheritance is seen in Naxos disease. Now, what is this particular Naxos disease? What are the changes or what are the features of your Naxos disease? In Naxos disease, remember, there will be woolly, hairy changes. Number 2, skin changes. And what will be that skin changes? That is palmoplantar keratoderma And the other one, yes, even you can make out this is also palmoplantar keratoderma. And along with this woolly hair changes, palmoplantar keratoderma, along with this, there will be ARVD, that is arrhythmogenic right ventricular dysplasia. So in arrhythmogenic right ventricular dysplasia, the ECG shows the presence of the epsilon wave. Right? The ECG shows the presence of epsilon wave. Now, I said you that this arrhythmogenic right ventricular dysplasia is mainly because of the mutations of the gene. Now, what are the genes which are responsible, or what are the gene mutations which are responsible for this arrhythmogenic right ventricular dysplasia? Remember, the genes which are being mutated is the Naxos gene. This Naxos gene, they code for proteins. Right, they code for proteins. Now, what are the proteins which will encode this Naxos gene? That is desmoplakin. Number 2, plakoglobin. Number 3, desmocolin 2. Right, desmocolin 2. So these are the proteins which will code for the Naxos gene. And because of this Naxos gene mutation, the individual will end up in arrhythmogenic right ventricular dysplasia. Now, this arrhythmogenic right ventricular dysplasia, remember, this is more common in men rather than women. And the ratio is around 3:1. Right, the ratio is around 3:1. And it is more common in people of the Italian or the Greek descent. In those individuals, this arrhythmogenic right ventricular dysplasia is more common. Now, this arrhythmogenic right ventricular dysplasia, if you see the incidence is around 1 in 5,000 people. Right, the incidence is around 1 in 5,000 people overall. Now, what will be the clinical features in these patients with the arrhythmogenic right ventricular dysplasia? See, the right ventricular myocardium has been replaced by the fat. Now, that fatty myocardium in the right ventricle will be acting as the origin of the abnormal impulses. So, there can be ventricular ectopics. Right, there can be the ventricular ectopics, right, or there can be sustained ventricular tachycardia. Right, there can be sustained ventricular tachycardia. Now, these abnormal fat within the myocardium, whenever it is generating this ventricular ectopic beats, these patients, they present with the palpitations. Right, these patients, they present with the palpitations, and they can also have the syncopal attacks because of the decreased cardiac output, or sometimes they can present with the cardiac arrest. Okay, sometimes they can present with the cardiac arrest, which is precipitated by exercise. Right, which is precipitated by exercise. So these are the clinical features what you will have in patients with the arrhythmogenic right ventricular dysplasia. So the first presenting symptom may itself be sudden cardiac death sometimes, and over the time the surviving patients also develop the features of right ventricular failure, which may progress to severe biventricular failure and dilated cardiomyopathy. So initially there will be right ventricular failure, and gradually it may progress to severe biventricular failure. right? It may progress to biventricular failure, and then finally the individual will land up in dilated cardiomyopathy. Okay, so this will be the progress of the disease, right? And not only that, there can be also the family history of the sudden cardiac death. Now, how will you diagnose this arrhythmogenic right ventricular dysplasia? As such, there is no a single diagnostic test for the arrhythmogenic right ventricular dysplasia. The diagnosis is made using a combination of clinical features, electrocardiographic features, and radiological features. And these are defined by the 2010 task force criteria. Now, what are the clinical features? Already I have discussed. The individual can have palpitations, the individual can have the syncopal attacks. These are the clinical manifestations. Alright, next. What will be the electrocardiographic manifestations in ARVD? That is what we are discussing now. In ARVD, you will have the presence of the Epsilon wave. Right? And this particular Epsilon wave, it is a positive blip in V1 and to certain extent even V2. So that is what is the Epsilon wave. Alright. That will be the ECG feature of your arrhythmogenic right ventricular dysplasia. Now, this Epsilon wave, it is one of the most specific finding, and this Epsilon wave is not present in all the patients of the arrhythmogenic right ventricular dysplasia. It is seen in 30% of patients of the arrhythmogenic right ventricular dysplasia. And apart from that, in ARVD, there can be also the T wave inversion. And the T wave inversion is seen from V1 to V3. And that is seen in almost 85% of patients. Apart from that, the S wave of the QRS complex, there will be the prolonged S wave, right? Prolonged S wave upstroke of 55 milliseconds in V1 to V3. Okay, so that prolonged S wave duration will be 55 milliseconds and it is seen in almost 95% of patients, right? And even if you take the QRS widening, the QRS widening will be around 110 milliseconds in V1 to V3. And there can be paroxysmal episodes of ventricular tachycardia with left bundle branch block morphology. So this will be the ECG changes in arrhythmogenic right ventricular dysplasia, but our point of discussion is mainly about the Epsilon wave. And this Epsilon wave, it is most specific finding. If Epsilon wave is present, it is suggestive of your arrhythmogenic right ventricular dysplasia, but it is not 100% sensitive. It is present only in 30% of patients with the arrhythmogenic right ventricular dysplasia. Now let me just show you the imaging, that is echocardiography of a patient with the arrhythmogenic right ventricular dysplasia. You see here, this is the right ventricle, right? So you can make out that the right ventricular myocardium is replaced by your fibrofatty tissue. So you can see that the myocardium, okay, it is completely sclerosed and it is completely fatty. Okay, so echocardiography is the first line investigation, right? Echocardiography is the first line investigation in case of the arrhythmogenic right ventricular dysplasia. And what does this echocardiography demonstrate? The echocardiography demonstrate the presence of dilated hypokinetic right ventricle with prominent apical trabeculae and dilatation of the right ventricular outflow tract. So you can see that here, these are the presence of the trabeculae. And apart from that, what are the other things that should be present? There should be dilated right ventricle. There should be hypokinetic right ventricle, right? And there should be prominent apical trabeculae, and there should be dilatation of the right ventricular outflow tract. So these are the echocardiographic findings in the ARVD. And what is the imaging study which will confirm the diagnosis? That is your MRI. MRI is the investigation of choice, right? This MRI, this can accurately demonstrate the structural and as well as the functional features of the arrhythmogenic right ventricular dysplasia. Now, what are those structural changes? The structural changes include the fibrofatty infiltration, and there will be thinning of the right ventricular myocardium. And the MRI can also demonstrate the presence of right ventricular aneurysm, right ventricular dilatation, and there can be even regional wall motion abnormality and global systolic dysfunction. So this is about the MRI finding in patients with the arrhythmogenic right ventricular dysplasia, right? And MRI is the investigation of choice. It will give you or it will show you the structural changes, and it can also give you the picture of the functional features of the myocardium related to your arrhythmogenic right ventricular dysplasia. Now, you take the histological diagnosis. The histological diagnosis can also confirm the diagnosis, but this can be diagnosed at the post-mortem. Okay, so what you need to do? You need to do an endomyocardial biopsy, right, during the time of the autopsy, and that will provide the definitive diagnosis. That will provide the definitive diagnosis. So this is about the histological diagnosis. This will also confirm, but the histological diagnosis is usually done at the time of the autopsy. Now, coming to the risk assessment of the arrhythmogenic right ventricular dysplasia. Remember, patients with this ARVD are considered to be at high risk of the sudden cardiac death. Right? They are at a high risk of sudden cardiac death if they have any of the following. Right? If they have any of the following feature, they are at high risk of sudden cardiac death. Number one, if there is history of syncope, then they are at high risk of the sudden cardiac death. Right? If there is any history of syncope due to cardiac arrest. Next, presence of recurrent arrhythmias. Right, presence of the recurrent arrhythmias, they are also the risk factor for the development of the sudden cardiac death. And these recurrent arrhythmias, they are not suppressed by any of the anti-arrhythmic drug therapy. Next, the third important risk factor for sudden cardiac death is family history of the cardiac arrest. In first degree relative. Okay, so these are the risk factors for the development of sudden cardiac death in patients with the arrhythmogenic right ventricular dysplasia. Now, what are the treatment options? In patients with no high risk features, the initial treatment is with the anti-arrhythmic drugs. So, in those individuals where there is no risk factors, in them you need to give the beta blockers. Right, in them you need to give beta blockers, right? That is your anti-arrhythmic drugs, which are nothing but your class 2 anti-arrhythmic drugs. Or you can also give amiodarone. Right, you can also give the amiodarone, which is class 3 anti-arrhythmic drug. So these drugs, they will suppress the catecholamine triggered ventricular arrhythmias. And currently, the most effective drug for the ARVD is your sotalol. Right? Sotalol is the most effective drug for this patients of arrhythmogenic right ventricular dysplasia. So these drugs, they will suppress the catecholamine triggered ventricular arrhythmias. But in those individuals who have Risk factors like history of syncopal attack, recurrent arrhythmias not suppressed by antiarrhythmic drugs, family history of cardiac arrest in first degree relative. If any of these risk factors are there, then the treatment of choice will be ICD, that is implantable cardioverter defibrillator. So patients with any high risk features, they require urgent insertion of an implantable cardioverter defibrillator, right? Next, the other treatment option is in patients with persistent symptomatic arrhythmias, radiofrequency ablation of the conduction pathway, this can be attempted, right? So these are the treatment options. And the other point is, in these patients with ARVD, if they can progress to biventricular failure, the heart failure, it is treated in the usual way like what we treat the heart failure. Like what is that? We give diuretics, that is mainly the loop diuretics, mainly to reduce that pulmonary edema component. Then the AC inhibitors mainly to reduce the afterload on the ventricles, and that will prevent the development of the cardiac remodeling. Then anticoagulants we give whenever there is the thrombus formation secondary to severe biventricular failure. And in severe cases, the cardiac transplantation may be required. So this is about the arithmogenic right ventricular dysplasia. So to summarize this arithmogenic right ventricular dysplasia, remember it is a disorder which is inherited. It has both autosomal dominant and autosomal recessive type of inheritance. Predominantly it is autosomal dominant. But one variant or one disease where you have autosomal recessive form is nothing but your Naxos disease. Naxos disease, it is characterized by woolly hairy changes, palmoplantar keratoderma and arithmogenic right ventricular dysplasia. And this ARVD is mainly due to mutation of the gene, that is Naxos gene. And this Naxos gene mutation or this Naxos genes are encoded by the proteins desmoplakin, plakoglobin and then desmocolin 2. And this is more common in women rather than men, and the incidence is around 1 in 5,000 people overall. The clinical features is mainly your palpitation, syncopal attack, and sometimes they can directly present with a sudden cardiac death. And over the time, like how will this disease progress? Initially there will be right ventricular failure followed by biventricular failure, and followed by that the individual will end up in dilated cardiomyopathy and congestive cardiac failure, right? How will you diagnose? Diagnosis is mainly clinical and then the investigations. Investigations, if you take ECG, you have the presence of the Epsilon wave, which is nothing but a blip at the end of QRS complex. And apart from the Epsilon wave, there can be T wave inversions, prolonged S wave, localized QRS widening, and there can be even VT as well, that is ventricular tachycardia can be there. And 2D echo will be the first line investigations that will show you the presence of hypokinetic right ventricle, and there will be prominent apical trabeculae and dilatation of the right ventricular outflow tract. And MRI will confirm the diagnosis. And what does this MRI shows? It shows the presence of fibrofatty infiltration, and there can be thinning of RV myocardium, RV aneurysm, right ventricular dilatation, regional wall motion abnormality, and there can be even global systolic dysfunction. That will confirm the diagnosis. And even your endomyocardial biopsy. But we do this endomyocardial biopsy mainly during the time of the autopsy. Coming to the risk assessment, remember these individuals, they are at high risk of sudden cardiac death if they have the following criteria. If there is history of syncopal attack, recurrent arrhythmia not suppressed by any of your antiarrhythmic drug, a family history of cardiac arrest in first degree relatives, all these are risk factors for the development of the sudden cardiac death. And the treatment options in those individuals who don't have the risk factors, you can give beta blockers or amiodarone can be given. And currently the most effective drug is the sotalol. Then, and finally, if you take the treatment of choice, that will be your implantable cardioverter defibrillator. And in patients with persistent symptomatic arrhythmias, radiofrequency ablation of the conduction pathways may be attempted. Right? And if the individual develops heart failure, so you need to treat the heart failure in the usual way. That is, we give diuretics, ACE inhibitors, and as well as the anticoagulants. And in severe cases, cardiac transplantation may be required. So this completes the discussion of the miscellaneous waves. One is your J wave or Osborne wave seen in patients with hypothermia, and the other one is the Epsilon wave seen in patients with the arithmogenic right ventricular dysplasia. Thank you very much.